Right, everyone, welcome to the English version of the 21st Century PT School. So today we'll be talking about anatomy physiology. We're going to be starting in the manual at page 71 or 70. So we're going to go through the anatomy of the human body, the terminology, how we move, our joints, and how it all links together with the function of the bones, function of the muscles, the type of muscles, type of fibers in the muscles, where they go to and come from, and then look at the physiology within the different systems. So for example, the blood system and nervous system, and then some small things to do with the accidents and injuries, and what a little bit of stretching and rehabilitation would do, and then finish off with some posture. So the word anatomy is the way to look at all of the body. So this is basically the facts of the body. And then the physiology is how it all wraps together and works by combining different systems and different parts of the anatomy. So the planes of movement are the first place where we start on page 72. So you can consider how we have three different planes that we talk about. We have our sagittal plane coming down the middle. We have our horizontal plane, and then we have our frontal plane. Okay, the pictures behind me show in the middle there that frontal plane quite well. So it separates front side from the back side. Sagittal will separate one side from the other side, and horizontal will cut straight through us. And so when we move on the horizontal plane, we are rotating. So each plane has two different movements. The first one here on page 72 is called the frontal plane. So therefore, our frontal plane, when we move along that, because that goes straight through us, we will be moving laterally and to a medial position. So that means that I'm moving laterally to my right, and then I move medially back to the midline. Laterally to my left, medially back to the midline. Then we have the horizontal plane. So when I move around the horizontal plane, I am rotating. And so therefore, my right side here will rotate externally, and my left side will have to follow and rotate internally. Now, if I were to do this with my arms, I would internally rotate and externally rotate. Shoulders, externally rotate, internally rotate. You can imagine it's the same for the legs. Sagittal plane of movement, so the one that goes straight down the middle, if I was to move along that, I'm going to be moving anteriorly and posteriorly, or forwards and backwards. The movement terms. Now we're looking at page 73, movement terms. 1, flexion, bending. I'm bending my elbow, I'm flexing my elbow. Then extension, I'm extending my elbow, so I'm stretching it out straight. I'm extending my back, so I'm opening there. We always look at the front side, so it might look like I'm bending my back, but we don't call that bending or flexion, we call it extending. This is bending your back. Lateral flexion means one side, so think of your head. I'm laterally flexing the right side of my neck. Okay, laterally flexing the left side of my neck. You can also then say I'm extending the right side of my neck here when I flex my left side of the neck. The next one, number 6 and 7, there is abduction, adduction. So I'm adducting, adding an arm to my body, you can think, and abducting. So I'm taking something away. So you abduct a child, you're taking it away. So abduction, adduction there. Rotation and circumduction. So we talked about rotation, internal, external. Circumduction is going around the full way. So I can circumduct my shoulder. I can almost circumduct my leg or my my hip. Almost circumduct. We always use it pretty much for the shoulder only. Palmar flexion. So palmar, hand, palmar flexion. Okay, pulling it towards us. Plantar flexion is pushing the foot on the gas. So plantar, pushing your foot into the ground. And dorsiflexion, because the top of the foot here is called the dorsal part of the foot. So we dorsiflex the foot. Think of a shark. As it's swimming, the dorsal fin comes up out of the water, and that's on the back side. So we can almost say this is the dorsal part of our torso. Okay, torso, body part. But we don't really say that's the dorsal part of our torso. But you can think of it in that way. So the top part of the foot is the dorsal part, because if it had a dorsal fin, well, it'd pop up out of the water. Supination is turning like so. And we can also use this in the foot as well. So it's when the foot turns over. So I supinate my foot. So when you have a high arch, you're calling that a supinated foot. Then pronation is when the foot collapses or the foot rolls in a little bit. So, or when we pronate our hand. So I take my hand from here, pronate it. From there, supinate it. Hyperextension. So this is an excessive movement in the joint. So basically my hands are flexed, or my fingers are flexed, my fingers are extended, my fingers are hyperextended. Elevation, up, depression, down, protraction, forward, retraction, back. Retract. Just think about retraction. Pull it back to you. Eversion, inversion. Everting means away from the midline. So with our foot, we can consider when I evert my foot, I'm taking it away from this is my right foot, by the way, taking it away from. When I'm everting, I'm pulling it inwards. So it's almost another word for external rotation or internal rotation. But we usually use it for our feet, these two words. Okay, so now we can describe ourselves with movement. Now we can describe ourselves with where things are in the body. So my chest muscle, my pec, is superior to my abdomen. It's above. My abdomen is inferior to my pec muscle. My foot is inferior to my tibialis bone here. Okay, anterior means front, posterior means back. Anterior side of my body, posterior side of my body. If I drew on my shoulder here, no, you can't really, no, it's not. Yeah, there it is, you can see it now. So this is anterior to the point, That's posterior to the point. Then we have ventral and dorsal. So ventral is here and dorsal is here. Now don't get confused too much. We don't use it that often, but it can come up in medical journals or so forth. So just remember ventral front, dorsal back. Think of a shark. Dorsal is on the back. Should be easy to remember that one. Okay, just repeat, repeat, repeat. That's the name of the game when it comes to anatomy and physiology. Okay, rewrite all this manual down, rewrite all these words that I say down. I know that I talk pretty quick. Pause the video, go back, replay me. Lateral, medial. Medial is situated closest. So my elbow is moving medially towards the midline here. My hand is right in the middle now. If my hand moves over there, it's moving laterally to the midline. But my bicep's still moving medial to the midline. Okay, so you can think I'm bringing my arm medially, I'm bringing my arm laterally. But when it comes to arms, we always talk about adduction and abduction. But we could say that the pen is lateral to the midline. But we could say the pen is medial to my arm. Medial to my arm. Then we can move into palmar. Oh, distal. Distal is lower. And proximal is above. Sorry, I just got a bit confused there where I was up to. So, the writing on the shirt is distal to the pen. The writing on the shirt is superior to the pen. So, proximal. Sorry, that was the word, proximal. My apologies. Okay, so the writing is proximal to the pen. The writing is distal to the pen. We then can say palmar and plantar on the bottom of your foot. Okay, then we have dexter and sinister. Now again, it's not often we use these. We always say dexter is right, sinister is left, but normally we just say right and left. So then we can go through a few things. So my elbow is distal to my hand. My hand is internally rotating, but my elbow is abducted from my body. My elbow is adducted to my body, and my hand is now prone. My hand is supine, my hand is prone. Okay, think about how your knees would move. In a squat, your knees can move externally or internally. My body, I'm doing a Russian twist. I'm moving externally with my left, but internally with my right. Hips or shoulders. Externally with the right shoulder, internal rotation with the left shoulder. Movement apparatus. So considering how we actually move, we're made up of a lot of bones and a lot of muscles, approximately 200 bones, 400 odd muscles. So when a muscle contracts, it moves the bone. When they work together, we have movement. So have a consideration of how we would move an elbow. You would need something that crosses the elbow, which will flex it. You would need something that goes around the back of the elbow to extend it. So every muscle crosses a joint. You do not get movement without a muscle crossing a joint. It's impossible. So when you're considering where a muscle goes from and to, or origin and insertion, consider that, well, the origin of a muscle must be above, on the scapula to the humerus. Now, with the bones, we have many different types of bones. We have rounded bones or pipe-like bones, like our humerus and our femur in our leg, our thigh bone. And then we have flat bones, like our sternum here, chest bone. And then we have irregular bones, which are just like our vertebrae. And then we have cubed bones, which are in our hands and our feet, these square ones. Carpals in our hands, tarsals in our feet. T for toes, C for... I'm just going to have to remember that one. Okay, then our bones obviously make joints when they come together. So we have a hinge joint. Just think of a door, opens and closes, nice and simple. We have a ball and socket joint, like our shoulders and our hips. It's a ball and it's a socket. Goes around, allows for a lot of movement. The more movement you have, the more complex the joint is going to be. So therefore, the more muscles and the more chance of injury, therefore, because many different positions, well, you better be smart and know how to use those muscles. When it comes to the vertebrae, we always call these pivot joints, okay, because the way you can pivot your neck, for example. And then we can have the ellipsoid joints, which are deep up in here in your hands. Then we have our saddles, and then we have our girdle joints in our feet, for example. So they just give different types of movement. You can imagine a saddle and an ellipsoid. They give a nice little rounded movement, or like this. Just think about riding a horse and how your legs would go side to side. Think about how this would happen here. It just rotates on itself or pivots on itself. And then we have a girdle joint, which comes around like so. It's like a girdle. Okay, both bones can move nicely around each other. All right, so the anatomy of the skeleton, you can consider the cranium. We can start at the top. All right, our cranium is not joined together when we're born. It will fuse together in the years afterwards. So we have a number of different bones in the cranium and the face. We're not going to spend a lot of time learning those. You can read those off the text. Trust me on this one, it's not often you'll actually use those names. Sometimes mandible is the biggest one. So remember mandible and you'll be fine. All right, then we have our vertebrae. So we're going to skip over quite a number of pages here, so just consider if you need to jump over the text instead of just listening to me. So from the top we have our vertebrae here. Think of the spine cut into three places when it comes to cervical, thoracic and lumbar. And then the extra two we have down the bottom is the sacrum, which is one fused bone, and then the little tailbone, which we call the coxa. Coming from the top, 7. Okay, just think breakfast, lunch, dinner here. Eat breakfast at 7 o'clock, have lunch at 12 o'clock, dinner at 5 o'clock. 7 vertebrae in the cervical spine, 12 vertebrae in the thoracic spine, 5 vertebrae in the lumbar. The sacrum is just 1, and then we have tiny movement in the coxa. Consider the structure of the spine. When the spine curves inwards for the neck, we call that a lordosis, and then we have a kyphosis for the thoracic, and then we have another lordosis for the lumbar. Okay, lumbar lordosis, it's very easy to remember. And then kyphosis, we're just going to have to remember that one. I don't have a trick for that. But basically it makes up a nice S shape, and therefore we get nice spring. We can flex and bend all around it. What gives us additional flexing and bending skills is through these things called the discs. Okay, the discs will allow for a lot of flexion, and it will keep our nerve endings, the yellow parts here, nice and safe at the same time. If we do have too much flexion or compression, then a disc can pop out to the side, and that's not good for anyone because it'll compress the nerve. This is where you get that funny tingling down your feet, because your disc has herniated or been pushed out, and so therefore compression on the nerve. The other thing that gives us a lot of movement is the thoracic cage or the rib cage. So the whole cage is made up of the vertebrae, the ribs, and the sternum. You can see how it's white colored here. Oh, sorry, white colored for the bones, clear color for the cartilage. Now that rib cartilage allows for a real nice bendy and malleable type of movement. So this is where we can really, just think of a dancer, how a dancer moves. They can move like that because of the malleability of the cartilage here. And then considering even more movement down the bottom, we have two floating ribs, and that's going to allow for this lumbar part of the spine and the lower thoracic to have a lot more movement, okay? Because we can flex the thoracic a little bit, but we can flex the lumbar a hell of a lot more. Okay, then coming through and down, we could start with the scapula and the arm. So the whole shoulder joint is made up of the scapula and the clavicle and the humerus. Clavicle is collarbone, scapula is shoulder blade, humerus is the arm bone, I guess. All right, so they join together with a nice little sliding joint up here with the what we call the AC joint, the acromion clavicular joint. It's called acromion because this bony part that comes off the side of the scapula, looking at it from the back here, this is your acromion. Then this little part down the bottom on the inside of the scapula, distal to the acromion, is called the coracoid process. They will make up a nice little place where a muscle can run underneath, but you can imagine if you break your collarbone, you're going to collapse that little bridge where my finger's trying to poke out, and you'll get a muscle impingement. Okay, so it's a very complex joint. That's why we need some rotation up here. And that's why the shoulder blade will move all around the rib cage so much. Then you can see the socket here isn't that deep, so that's what allows for so much movement of the arm. Okay, up and around and down and in and out, because as you move in, you can imagine the clavicular will roll, the scapula will come over the top and follow around. So other little things to consider: anatomy of the arm bone. Humerus is these little divots on the side. Okay, these little processes help attachments for the muscles. All right, then we can come down to our elbow. We have our ulna is on the thinner bone on the inside, or little finger side here, and the radius is on the thicker bone on the thumb side. I used to remember this by saying radical. I was born in the 80s, and that we used to say things were radical, man, and put our thumbs out. That's rad, radius. In our hands, the square bones are called the carpals. Then the middle part of the bones here are called meta. carpals, and then we have our phalanges, our fingers and our thumb. So what I suggest is just taking a pen and paper, drawing your own skeleton, and then writing in all these names. Repetition, repetition. Okay, the lower limb now. Made up of our pelvis bone. Our pelvis bone is broken into, this top part is called the iliacus or ilium. Depends kind of what journals you read, but ilium is quite fine. And then this part at the front, which will poke out right there, just above our bits and pieces, that's called our pubis. And then underneath is called our sit bone or the ischium. Right, so then we have another ball and socket joint, which is our femur. Our femoral head, which is the ball, goes into the acetabulum, which is the socket part, what we call the socket. Okay, note well, on the leg bone, we have a big bulge here, and that's called our greater trochanter. If I turn slightly, on the inside, we have our minor trochanter. So then we have our big long femur, and then we have our patella, and of course, then the lower leg is the tibia, the big thick one, and our fibula, the thin small one on the outside. Then for the foot, we have tarsals with a T. Then we have metatarsals, the middle ones, and then we have our phalanges, our toe bones. So very similar to the hand, but with a T instead. Okay, if you ever get confused, just think of toes. And then the other one, hand, must be carpal. Okay, now having a consideration of the bone, long bones hold bone marrow. Okay, so a lot of our blood is made in the bone marrow. So therefore, inside of these long bones, it's pretty hollow, okay? It's with a mushy, soft substance inside. So from the mushy, soft substance in the hollow hole, we then have spongy bone. So it looks like a bee's hive. It's called sponge bone because it's full of little holes. And then you have a real thick layer called compact bone or hard bone. And then we have a skin that goes around all of our bones called periosteum. The word peri means the most outer, generally. So periosteum, osteum is like Latin for osteo. Osteo is bone in Latin. Whenever you hear the word osteo or osteum or osteocyte, that's a bone cell, osteocyte. Okay, so that's all of our bones, pretty much. We then move through to the actual joints itself. So coming back to my leg one, I think it's easiest to explain. Inside our acetabulum and over the ball of our, the head of the femur, the ball part, we have cartilage. Okay, this cartilage is a nice, soft, reasonably soft but compact substance, the same as what's on our ribs here, cartilage, rib cartilage, and this is joint cartilage. Around that joint cartilage is a lot of water and lubricant, and that's what keeps our joints nice and mobile. If we keep walking in a bad position or do an exercise in a bad position, we're going to eventually wear that out, and then it comes bone on bone, and that's when we get arthritis, and which is inflammation of the bone. how a joint will stay together is by a ligament. So, and a joint capsule, what we call a joint capsule. So we have ligaments that will hold one bone to the other bone. Different from a tendon. Tendon is muscle to bone. And then we have a big, thick network that comes around and holds all the water inside the joint, and we call that a joint capsule. We can then, therefore, speak a little bit about the knee, because the knee has another special piece called meniscus. And meniscus sits on these little grooves here to help give extra added stability and strength to the knee. And that meniscus helps with the movement and protection of the knee joint. And that sits in the middle there. So you may have heard of meniscus tears before, and they can become very painful. So when we consider then the muscles to do the movement, the muscle, the bicep, for example, will go from one side of the elbow to another. Okay, so when a muscle contracts, it will flex. When the tricep contracts, it extends. Okay, different function for the different movements. When it comes to, I think now is a good time to consider going through how the muscle will actually contract. So we can consider, especially down on page 91, we can see a nice big thick muscle, then a thinner, then a thinner, then a thinner. So basically, muscle will be made up of millions and millions of fibers on the smallest level, but then they get bounded into little bundles. More bundles will then get bounded together, and then you eventually have the one muscle. The muscle fibers themselves, they will reach a certain point. So we call this the muscle belly, and then on the ends will become tendon and insert into the bone. What you need to consider is each fiber will have what we call a sarcomere. Okay, now we're on to a microscopic level, and then the fibers will have synapses, the little nerve endings that come down and trigger the muscle to come together, or the fiber to come together. And then when a lot of fibers come together, boom, that's when we see the movement. So when we have little micro movements, like you're holding a plank and you start to shake after about a minute or so, that's little micro movements happening inside of the muscle because it's getting pretty tired and they want to let go, but you keep telling them, no, stick together. When we put it all together, we have what we call a motor unit. So nerves, muscle fibers, and so forth is a motor unit. The different types of fibers now can be considered. So when we talk about type 1 fibers need to use oxygen. Oxygen will then obviously allow for a nice process to go over and over again. So consider marathon runners will have a lot of type 1 fibers. Weightlifters will have a lot of type 2 fibers. So Olympic strength, weightlifting, Olympic lifting will have type 2A and type 2B in a lot of numbers. So type 2A, you'll get a few repetitions out of it and it doesn't need to use oxygen, so we call it anaerobic. And then type 2B, you get about one use out of it, so you can do one movement and then you're exhausted. So you can train these up by doing those sort of movements. You can improve them, but there is a pretty limited amount that you can do. So you can run for about maybe 10 seconds without taking a breath, but your muscles start to burn and then you won't be able to sprint as fast. You'll have to back off and use the type 1 fibers that work like a jogging instead of sprinting. Proprioceptors are a really important thing to remember because they sit around our joints. So proprioceptors, they will allow us to close our eyes and touch our nose. If we drink too much, we lose too much alcohol, we lose the ability to understand and how to use them properly in a subconscious level. So therefore, that's why you see drunk people stumbling all over the place. We can then move into tendons. So tendons will, as I said, attach the muscle into the bone. What we can consider is that there's a lot of short tendons and a lot of long tendons. Now, the short tendons will obviously be very strong, and the long tendons will have a lot more flexibility here. So what we need to think about is if you have a long tendon, well, that's designed to really stretch you out and go long. If we have a short tendon, then it locks in the joint really well. Excuse me. So, tendon is a formation of collagen fibers after the muscle fibers. You may have heard of fascia. This is where fascia starts to creep into anatomy and physiology, but that's another course. Then we come into our muscles. So, best way to think about this is what type of muscle, shape, and fiber direction a body part has. And then that can give you an indication to how if the muscle is going to produce a lot of power or a little bit more on the stability side or open and close things. So that, for example, food can come down into our stomach, or we can kiss somebody or blow a whistle. So thinking about a circular muscle, we have that around our lips and around our belly buttons and a number of other places in our body I shouldn't need to mention. We then have what we call pennate muscles. So pennate muscles, it's an angular type of fiber. Okay, so we have a unipennate muscle, which is just one angled, so the muscle's on an angle. Or we have a bipennate, which is two different angles that come into a midline like this. So when they contract, shoots power up. Multipennate, the best example is the deltoid here. So you have an anterior, mid, and a posterior deltoid muscle. So that basically will be a really strong one because you've got a lot of fibers coming from many different directions there. Then we have parallel fiber muscles. So parallel basically just mean one direction in a straight line. So you can think if a straight line, it's going to be really flexible and close up really well. And then we have what we call a fusiform. So it's like almost like an egg shape, okay? And so it comes around and matches on the bottom and comes around and matches on the top. Then we have our last one, which we call a convergent muscle. So the convergent muscle in our body is our pec. So when the pec comes over towards the arm, it twists on itself. So if you hold your pec here and you twist your arm, you can kind of feel how thick it is. It's going to really thicken up, just like a piece of rope if you were to tie up a boat, for example. Now there are three different types of muscles. There is the skeleton muscles, skeletal muscles. They join all of our bones together and make us move. Then we have our cardiac muscle, which is our heart. And then we have smooth muscle, which makes up blood vessels, our intestines, our stomach, our esophagus, for example. So when you swallow, it will close. And as soon as one part of it closes, the top part opens again. So think of how a snake would move. It's kind of like that, okay? Very smooth, muscular contractions that will push something along. Now we can actually talk about the actual muscles itself. Now, I've said before, repeat, repeat, repeat. I can't go through every single muscle origin and insertion or origin and attachment. So I want you to do this for yourself. Use Google, use books, use the manual in order to get the understanding of where the muscle actually comes from and goes to. This is where the name or the areas of your bones become extremely important. For example, the greater trochanter in the leg, because the greater trochanter is on the outside of the leg bone here. Any muscles attaching to that will naturally lift the bone to the outside. Any muscles attaching to the trochanter minor, which is on the inside, will kind of move the bone in and into internal rotation and medial movement. So this is why it's so important when you're learning the skeleton, understand that this is the medial epicondyle of the elbow, where the coracoid process would be, or the acromion process, because that'll help you understand how or which muscle is moving in which direction, the joint in which direction. So starting from the top, we'll go through the bicep 2. So there's 2 muscles. We have a long one. Basically that means that it goes all the way up into the scapula on the outside, and then we have a short one that comes up into the inside part of the scapula. Okay, then they insert underneath the elbow. So that's why a bicep will contract us or flex the elbow. Because they insert into the scapula, you can have a consideration if you're lifting too much of a heavy, doing a bicep curl with a heavy dumbbell, then your scapula will fall forward. If your scapula falls forward too often, you're going to encourage wear and tear of your cartilage, and therefore encourage arthritis later in life. So what I'd like you to consider is when you're doing your bicep next, pull your shoulder blades back and feel how much extra it's working your bicep there. Tricep, 3 muscles from the back side of the arm, okay, from the distal part of the elbow again. One of the tricep muscles goes into the scapula, the other 2 go into the top of the humerus. So again, one of those tricep muscles will help us pull back the scapula or stabilize the shoulder there. So this is where now you can start to consider that if the tricep opens up the arm or extends the elbow here, the one of the tricep muscles is also going to work synergistically to the scapula. So this is where we talk about synergists and agonists and antagonists. So a synergistic muscle will work symbiotically or with a similar movement to another muscle, which is the main driver. Okay, so the main driver to pull the shoulder blades back are the rhomboids, but it will work synergistically with one of the tricep muscles. An agonist will be a smaller muscle generally that will assist with the movement as well. So a small muscle, the brachioradialis, which crosses the elbow as well, is a agonist muscle for elbow flexion. Antagonist means the opposite. So the bicep is an agonist for elbow flexion, and the antagonist muscle we call the tricep. Every muscle has an agonist and an antagonist, or so just consider that. Hamstrings and quadriceps. Quad is the agonist for straightening the knee or extending the knee, so the antagonist is the hamstring. When we bend the knee, the agonist is the hamstring, antagonist is the quadricep. It's important to remember those because basically if you have an injury or a scar or a shortening of one of the muscles, then the opposite, the antagonist, will have to work twice as hard to do its movement. So if I cut my bicep, stitched it back together, it's going to be short. So my antagonist to the bicep, the tricep, is going to have to work doubly as hard to straighten the elbow. We can then come into the chest quickly. So we have the big pectoral muscle, pectoral major. So that's the convergent muscle that comes off all the way down the breastbone or sternum and comes over towards the inside part of the elbow, humerus here. And it has a little brother muscle, I call it. It comes off the coracoid process onto the first few ribs, and we call that the pec minor. So the pec minor will bring our shoulder forward or protract, and then you can definitely feel your big pec muscle if we move our arm in. So have a consideration of just doing this, getting someone in a headlock or doing a big cable flies like this. You can imagine you're using your pec minor synergistically with your pec major, synergistically with your bicep, your coracobrachialis. So you can see how 4 or 5 muscles work all together to do one movement, because one will pull the shoulder blade in, one will rotate the arm a little bit, one will pull the arm across, etc., etc. Now, while I'm on this topic, this region in the shoulder we call the brachial region. So that's why a lot of these muscles are called the brachialis, coracobrachialis, brachioradialis. Okay. Then we can move into our hip. So having consideration now of the hip flexors, very important muscles. Inside the big hole here in the hip, we have a muscle called the iliacus, and then it works synergistically with a muscle coming from the front side of the ribs down into the leg, and we call that one the psoas muscle. Okay, so the psoas and the iliacus form our hip flexor. So basically it will, because it attaches onto the inside of our leg, here it will pull our leg up and a little bit inwards. Or it will assist in leaning forward with straight legs. Okay, it will pull my hips downwards, or flexing our hips. Then have a couple of special muscles to mention in the lower leg around our quadriceps. So our quadriceps are four muscles, but we have a number of others that surround them as well. So our quadricep is made up of the vastus muscles, vastus lateralis, vastus intermedialis, vastus medialis. So think lateral, outside, intermedius, in the middle, medius, on the inside. Then we have the big one that comes over the top, which is called the rectus femoris. It's one of the few, there's a number of, 3 or 4, I think, off the top of my head, that cross 2 joints. So those vastus muscles start here, cross the knee joint, allow for the knee to go straight. Then we have the rectus femoris, which starts at the very top of the hip bone here, the hip of the point of the ilium, and comes over the knee joint. So when we hold our knee straight, that will help us with our hip flexion. Okay, it'll basically let me stand here and lift my leg up with a straight knee. Then we have 2 special mentions, the sartorius, which will come from that point as well and go on to the inside of the knee down the bottom. So that helps us with external rotation there. It's going to help pull me up and out Okay, so if you were to do a bit of a swinging kick to the outside, that will help with that movement, and will also help with stabilizing the knee as we're bending or doing a squat, for example. The other special muscle is called the TFL. The TFL sits just off the side here. It's a very thick thick muscle, and that has a big band that comes down to below the knee on the outside. Now this band is what we call the iliotibial tract. Now that band has the big butt muscle that the gluteus maximus that attaches to it as well, and that will help control slight external rotation of our leg. So then, speaking of the butt muscle, we can then consider the butt itself. So what we can really feel when we grab our backside is the gluteus maximus, gluteus minimus, and gluteus medius. The medius and minimus will help with controlling the hip stability so our leg doesn't pop out the side. The gluteus maximus will help us stand up, okay, and a little bit of rotation in the leg there. So think before what I said about the greater trochanter, where the bone is on the outside. So guess where all these butt muscles join? Pretty much the greater trochanter, and then also form part of the iliotibial tract. We have a number of rotator muscles in the middle of the hip. Now they help with rotating the leg out to the side or into the knee into the middle. So have a consideration of I think there's 6 or 7 there. Just remember and consider where they attach. That's going to help you understand what kind of movement they're going to give. We then also have the ones that sit on the inside of the leg that will oppose the ones that sit deep inside the butt. So the piriformis is the main one that comes out of here. But we also have what we call the adductors. Sorry, wrong way around. The adductors are the muscles that come from the pubis bone, right in the middle there, and they'll come into the leg. Different angles, different sizes, different shapes to give different stability of leg adduction, as where you can see how the ball and the socket moves so much, and the knee can go in, out, forwards, backwards, etc. So they will work synergistically to assist in adduction and a little bit of internal rotation or external rotation, depending on where they're sitting. The hamstring is made up of 3 muscles, but we have 4 specifically. Sorry to confuse you. We have the 2 inside hamstrings come off, or actually all of your hamstring muscles come off your ischium or your sit bone. 2 of them come to the medial side of the back of the knee, so the tibia here, and the big one, the bicep femoris, comes to the fibula bone down here, the outside of the knee. Now you also have a short head of the bicep femoris, so bi meaning 2, so the one muscle has 2 muscles. Okay, so the short head of the bicep is a unipennate muscle that contracts really hard, really quick, and will stabilize the knee joint as we bend or extend the knee. Okay, then we can come down into the calf, and the calf has 3 different muscles here. So it has the gastrocnemius, which has a medial head and a lateral head. The gastrocnemius attaches above the knee, so the knee must be straight to activate this properly. So if you stand, and the movement here is to plantar flex the foot. So if you stand still, straighten your knees, come up onto your toes, you're using the gastrocnemius. If you bend your knees and come up onto your toes, you're specifically using the soleus muscle, because the soleus muscle attaches to below the knee, from the ankle bone to below the knee. So it's still going to push your foot down, but it can push your foot down with a bent knee. On the front side, we see another similarity when it comes to synergistic muscles working together. So as we lift the foot, it's called dorsiflexion. The dorsiflexion will be primarily come from your tibialis anterior, from the outside of the knee to the arch of the foot. So that will pull the foot up. But we also have our extensor digitorum muscles and our extensor hallucis. Hallucis means big toe. So when you pull your foot up and all your toes come with it, you're using all three muscles. You can isolate your hallucis muscle, big toe muscle, but it's pretty hard. You don't do it too often, so you lose that ability. Then we can now come back up to the top and consider the rotator cuff muscles. Now, as the name suggests, they rotate our shoulder and our cuff. So this is kind of a cuff here. Think about a shirt. You have your cuffs of your shirt. It's the little parts that sit outside. Anywho, we have 4 rotator cuff muscles. Subscapularis, like a submarine, sits underneath, under here. Then we have infraspinatus, which is on the inferior part of the scapula. You then have your supraspinatus, which is deep in here, in this hole here. You can feel it on yourself if you poke the shoulder. And then you have a small muscle called the teres minor. Okay, it's all the way deep up in there, hard to press, but you can definitely feel it if it's tight. So the infraspinatus and the teres minor will rotate the arm backwards, external rotation. The subscapularis will pull you across or internal rotate of the arm, because they sit or they insert into different parts of the arm bone. The infraspinatus and teres minor insert here at the back side. The supraspinatus inserts here on the inside. Then we have our supraspinatus, which inserts a little bit on the front side, but more, you could say lateral anterior point. So it will allow for a small internal rotation, but mostly a adduction. Then you can consider the shoulder. The shoulder blade has another thick one called the teres major, which goes onto the inside of the arm. So that will assist in internal rotation as well, but mainly pulling the arm in or adducting. Okay, serratus muscle. The serratus anterior sits from the inside of the scapula and comes onto the ribs here. It's what we call the punching muscle. So basically, as you push like this and you hold your hand here on the ribs, you'll feel that contracting. So guess who uses that a lot? Boxers. Breathing muscles, intercostals. They're in between every single rib. Now we come into the core. So we have 4 different core muscles. Well, we have more than that, but for the introduction to anatomy physiology, we'll keep it simple for you. We have our 6-pack, which will flex us. Comes from our top of the rib, or the bottom of the ribs here, and to the pubis bone all the way down the bottom. Then we have 2 oblique muscles. So oblique is angled. So they will help us bend to the side and roll a little bit forward. So imagine doing your Russian twist, medicine ball from side to side. Then you're going to be using a lot of your obliques there. Then we have the big transverse muscle. So it transverses all the way around from the spine to the middle here. Now this is what I usually call the plank muscle. When you're doing a plank, this holds everything together, or you can think of it as a corset or a big belt that would go from here all the way to the hips. So when that contracts, it holds everything in. All right. It will also naturally pull on the other muscles to stabilize the rest of it. So again, acting like a synergist. Erector spinae muscles. So erector means coming up, spinae, spinal. So these erector spinae muscles go all the way down the spine and into the hip bones as well. So we have a number of different, we have ones on the outside, ones more on the middle, and then ones close to the spine itself. Very long, hard-working muscles to keep us standing upright. So spine extension or back extension. Then we have our trapezius muscle. Our trapezius, you've probably all heard of upper trapezius, but we also have a mid trapezius and a lower trapezius. The whole thing itself goes from roughly the top of the neck there, out to the shoulder, and then into the spine below the shoulder blades. So it's almost a triangle shape. So it's a very strong muscle that works a lot with the deeper layers of the back muscles, especially the rhomboid muscles. So the rhomboids are the ones that pull our shoulder blades together, like so. And we have two of them, rhomboid major and rhomboid minor. The minors will come from the neck, or just on the base of the neck out, and the majors will just come pretty much straight across from the spine to the shoulder blades. So if you pull the shoulder blades back and just let them come up a little bit, then you're going to be attracting the rhomboid majors first, and then rhomboid minors second. We then also have a big muscle that goes from the scapula up into the neck, and that's what we call the levator scapula. So that pulls the scapula up towards the neck. So again, that would work with the upper trapezius to pull us up. Some deep neck muscles to help you remember this. Capitis is the Latin name for skull or cranium. Cervicus is the Latin name for the cervical spine. So if you see the word splenus cervicus, that means that it's going from vertebrae to vertebrae. So roughly down here, base of the neck to upper neck. Help us do that. Look up to the sky. Then if we need to look up to the sky and look even more, we're going to engage the capitis muscles that come up into the skull itself. A fun one to remember, now this is why it's so important to understand where the muscles attach and come from, is the sternocleidomastoid. So, sternum, sterno, clado, clavicle, mastoid. Mastoid process of the bone behind your ear there on your skull. So that's a good word to use. Sternocleidomastoid makes you sound smart, but additionally it makes you understand that if you know where the muscle attaches to, then you know exactly what it's going to do. It's going to help pull your head forward and rotate a little bit, and also stabilize as your shoulder comes up and around, and you'll feel it. If you pinch it just there, move your shoulder, you'll feel it contract. If you move your head forward, you can feel it contract. All right, so that's our muscles and bones. Thank you. Moving into now the types of muscular contractions. We can see the representation in the manual as basically we can see it's a bicep curl here. So the more weight that I would have away from the arm, it's going to put more pressure onto the fulcrum. Okay, the fulcrum is right here, where if the weight was sitting there, well, it'd be a lot easier, wouldn't it? More weight, less weight. Same weight in total, but the further it goes away from the fulcrum, the joint, the more you're going to have to work. So, different types of muscle contractions here give different results. So, a concentric contraction is when it comes together. So, think of the word C, or think of the letter C, concentric. So, it'll come together. Then we have, if I was to hold the weight and let it come out slowly, the bicep is eccentrically working. Now, if I was to pull a cable or a band, well, I'm going to be concentrically using the tricep. If I was to hold still, that is called isometric contraction. Okay, so this is where it gets a little bit confusing. So just think, concentric, eccentric, nice and slow, and isometric. So it's, you can, metric, well, you can think you're measuring something. Maybe that's an easy way to do it. Now there's also one more, and that's called isokinetic. Isokinetic is under a consistent speed. Now, it's not often that we use this except in water or hydraulic machines. So basically a swimmer will be using a lot of isokinetic contractions because they are moving their arm in water. Special hydraulic machines are being developed so that we can also build up this idea of a consistent muscular contraction. Excuse me. Moving into a little bit of physiology now, where different physiology is after training. Excuse me for 1 second. Okay, so after training here, we have probably all felt that pain, and this is called delayed onset muscular soreness, or DOMS for short. Basically, it will come to us when we wake up in the morning after a heavy session, and it can last from 24 to 72 hours. Now, this is the inflammation response of the fibers that you've broken down and the damage that you've done to the muscle. Now, never fear, because we need to damage the muscles to rebuild them. We need to stress muscles. Just like any adaptation to become beneficial, it needs to be stressed, or the object needs to be stressed. So how do you make a house nice from an ugly looking house? Well, you damage the ugly looking house and you renovate it and you make it look nice. You have stressed the house to make it look nice, and it has adapted into a pretty looking house. Now, it's exactly the same with the human body. If you want to get a better body, then you have to break it down and let it rebuild and make it better. So don't be afraid of a bit of DOMS and inflammation. Of course, you don't want too much inflammation, and because then you'll burn the whole thing down. So that's effectively what DOMS is: inflammation of your muscles after too much or a lot of contractions. You have short-term effects, which basically means that you're going to increase the blood flow, which is going to puff up the muscles, so hypertrophy, and therefore you're going to build a lot more muscle mass afterwards. You also have a lot more muscle coordination because you're telling the muscle how to adapt into different movements. So if I do a bicep curl with some rotation, then you'll get much better at that. It'll become a lot more natural for you to lift the arm and put something on the back seat of the car, for example. The circulatory system will spread out and insert into these areas a lot more because those muscles are demanding a lot more oxygen. So therefore you'll have a lot of capillaries that grow out into it. And therefore you'll also improve the function of your lungs because your lungs will need to process oxygen, carbon dioxide in a more efficient way. And this is what the human body does. It processes. When you use it, it becomes more efficient. So therefore, different types of training, cardio, strength, mobility, end range training, functional training, calisthenics training. This is why all training methods are important to cover. If you just do one type of training, you're training one type of system, and you will get some flow-on effect to other areas or other systems, but really the most effective is to use a bit of everything. Long-term benefits, we can actually go on to a DNA level here and talk about gene expression. Then the cardiovascular response will be much better for your training, so therefore better cardiovascular system, less cardiovascular disease in the long term. Noticeable trends have been also flowing into different types of cancers and autoimmune diseases as well, because don't forget, when you move, you actually use your nervous system. Your nervous system will become healthier and stronger, and your immune response, because there's spike of inflammation, down it goes over 2 or 3 days, spike of inflammation, that's controlled by your by your immune system as well. Your immune system will thank you later. If you're strong and fit, you won't get as many illnesses. Different parts of the physiology now. We have the bloodstream, the circulation system, or the blood vessels. So, circulatory system is made up of obviously the heart, veins, arteries, and capillaries. Now, I want you to consider that arteries are all about oxygenated blood, veins are all about deoxygenated blood. When I'm doing a muscle contraction, I do a lightweight 20 times. The muscle gets tired, yes, but it's using those type 1 fibers, so it's using a lot of oxygen. So those arteries are going to pump a lot of oxygen in, but then of course the muscle's being used, so we have byproducts or metabolic waste, and that will then be pushed out into the veins that you can see. There's one there. That vein will then go back around the system, back into the heart, back around the lungs, pick up the oxygen to take all that back out to the rest of the body. All that byproduct is all filtered through the liver and the kidneys down here. The structure of the blood vessels, you can think they're made up of smooth muscle, okay? The arteries are obviously the big ones, and then the capillaries are the small ones. So think of an artery being like a tree trunk. The capillaries are all the roots of the tree that pick up and disperse a lot of nutrients. The idea here is to have a nice fluid, what we call pulmonary circulation. So, the heart is made up of 4 different chambers. Okay, your ventricles and your atriums. Now, this is where you need on this video I can't just give you simple diagrams, but you can simply Google the heart or blood flow through the heart and you'll see it straight away. So what we're looking at is how the heart will pump from the atrium into the ventricle. The ventricle will come out through the lung system, come back into the other side of the atrium to then push down to the ventricle to then have its almighty bang and spread out through the body. So consider now that each part of the heart has its little job and it has little flaps to open and close. So when we hear the dunk dunk of the heartbeat, the small sound or lower sound is the atriums and the bigger sound is the ventricles. Okay, so then the ventricles will pump the blood out of the heart. The one side of the ventricle will pump blood out of the heart around the lungs. Then the blood comes back in and then goes into the atrium, then the ventricle, to then be pumped again all around the body. So we have very big arteries and veins in this instance. So you can almost put a finger, well, you can put a finger in the aorta that comes out of the heart and for the rest of the body. One part of the aorta comes down, the descending, one comes up, the ascending aorta. Now, it's going to get confusing here because there is one vein in the human body that has oxygenated blood, and that's called the pulmonary vein. Any blood vessel that sends blood back into the heart we call a vein. I'm sorry, I didn't make the rules here, but when the blood goes around the lungs, picks up all the oxygen and comes back into the atrium to be eventually pushed through the ventricle to the rest of the body, that vein or that vessel is called the pulmonary for your lungs, pulmonary vein. Okay, so you can see in your manual, you can read and you can see the diagrams. As I said, I would highly recommend using Google to get a number of different diagrams and have a little follow the arrows and you'll figure it out. I trust you on that. Okay, blood, we have about 4 to 5 liters, 5.5 liters or so. The blood contains a number of different cells. The red blood cells, the white blood cells, immune, and things called platelets. Platelets will help the blood coagulate or join together in order to stop bleeding. So if you have too many platelets, you're going to get a stroke or a heart attack a lot easier than others. But if you cut yourself, good for you. You won't bleed out so much. If you have low platelet levels, then any bump or scrape, you're going to bleed or bruise very easily. So just think, if you don't have what we call homeostasis in your body, so a good even balance of everything, well, your immune system, if you have too many, you'll attack too much. If you have too many platelets, you'll clot too easily. If you have too little platelets, you'll bleed more. If you have too little immune system, you won't fight infection or inflammation very well. So what the blood does is it picks up little signals as it goes around the body, and it will assist all the other systems in the body, the hormone system, your nervous system with your brain, etc., to keep a nice even level there. Little thing to consider is cardiovascular disease. or specifically here, we have coronary heart disease. Coronary blood vessels are to do with the heart specifically, and you can see in the diagrams there that you have plaque on the inside. Okay, this plaque is a buildup of cholesterol, and that buildup of cholesterol, for whatever reason, there's a lot of different explanations why, so I'm not going to get into I heard this and I heard that. It's going to build up on the inside of the wall of the artery, and then eventually cause a blood clot or stop the blood flowing through. If you stop blood flowing through, well, then you don't have oxygenated blood. The heart is made up of cardiac muscle and needs a lot of oxygen. So therefore, if the heart muscle itself doesn't get oxygen, well, it's not gonna beat. So unfortunately, you have a thing called a heart attack. So there's a number of different reasons why we can get coronary heart disease or plaque inside. It's a lot to do with physical activity, high blood pressure, smoking, depression, a lot of stress can do it. Poor food can do it as well, so nutrition's a big one there. Older age, naturally, as we get older, we can't help certain things, unfortunately. But you can assist the body through good diet and exercise, as always. So that's why we suggest at least 150 minutes a week, so 30 minutes a day. Now that's the bare minimum, okay? So if you're a young, healthy person, you should be doing at least 45 minutes to an hour a day of movement and at least half an hour of good pulse movement. So, 130, 140 beats a minute is what you should stay at. So basically, get on your bike and ride your bike more often. Get out of the car and walk the rest of the way, or jog the rest of the way. Yeah, it might be a bit sweaty, but hell, it's better being sweaty than being dead at an early age. The nervous system. Now we have a lot of sensory nerves going through our body, and we have a couple of different systems. We have the autonomic nervous system, we have the parasympathetic nervous system, and we also have our sympathetic nervous system. So to clarify a lot of this, autonomic nervous system, that takes care of all the things that will happen automatically. Your sympathetic nervous system is stress, fight or flight. So whether you run or whether you stand and throw punches. Now that stress nervous system, nice and easy to remember. Stress, sympathetic, S and S. Parasympathetic is your rest and digest. So this is where you calm yourself right down and you breathe through stressful moments. Instead of activating your sympathetic nervous system and letting that take over and getting like this, you can consciously calm yourself and activate your parasympathetic nervous system, or PNS. Your ANS, your autonomic nervous system, as it's spelt out there, it will really help all of the small things that you don't think about. Your blood pressure, the way that your food is digested, how your kidneys work, how your liver works, and how your immune system works. And including your psyche, actually, I can throw in there for you. There's some somatic nervous system. Now somatic means your physical body. So that's a poor way to explain it. Sorry. Somatic means basically your muscular system. All right. So this is a very important part of any training program. to have a little understanding how your somatic nervous system will come from your central nervous system. I put my hand on my head because that your central nervous system is your brain and your spinal cord and those little yellow things sticking off the spinal cord here. That goes out into your arms, legs, and muscles. Then that side of it's called the somatic. Your sensory nervous system now is also connected to your central nervous system. And all your senses, like all of the touch, temperature, and that sort of thing as well. So a nerve, what you can think of a nerve is you obviously have the big thick ones that you can actually see in pictures and skeletons like my friend here. But then you have tiny little nerves that you can't see at all. And they're the ones that, just like blood vessels, they reach out all the way deep inside muscles or deep inside our eyes. So just think how blood vessels will go from a thick aorta to capillaries, really small ones that you can barely see. It's the same with the nerves. They start really thick and then branch out and become almost invisible. The endocrine system. Now the endocrine system is our hormones. So we have a number of different glands for our hormones, and that will react with our autonomic nervous system, but also can be controlled by our central nervous system if we exercise correctly or if we don't exercise correctly. So the hormones, this is why after a big pump session in the gym, the hormone mainly released is testosterone. This is what makes us feel good. It also combines with a number of other hormones, so it's never just the one. When it comes to hormones and training, you can consider the classifications. So we have the steroid hormones, the peptides, and the enemies, which is the amino acid hormones. Now, they all have unique little classifications on a chemical level, and each one will react with a receptor. So one hormone has one receptor. So when the hormones float around the blood, then they might pass one of the cells and they'll go, oh, there's my receptor, and hook in or lock in. And then that connection is then what produces the functional change in the cell. And then the cell will go, oh, we need to be active, be more metabolic, and produce more energy perhaps. Or it might produce that little, oh, we need to produce more immune response mechanisms or cells. Or start producing building blocks like with amino acids in order to start replicating more muscle cells because we just train so much. And we need to build more muscles because we need to adapt to lifting heavier weights over and over again. And then we also have special nerves that influence the sympathetic nervous system. So the stress side of us. So if we don't keep ourselves in homeostasis and we produce more of these because they're not counterbalanced by other hormones, then we elicit the response of the sympathetic nervous system becoming more stressed. Sometimes it can be a good thing. We might need to run away from something. We might need to run to the police station. So we need that stress sometimes, so don't be too fearful of stress as long as it's used correctly. Insulin is an important thing here. So muscles are a big provider of different insulin things. So what you need to consider here is how the insulin basically breaks down sugar, so it regulates carbohydrates and fats for metabolism. If we have too much insulin, then we're going to break down too much and not have it ready for use in our muscles. Insulin helps reduce levels of glucose in the blood by promoting its absorption from the bloodstream to skeletal muscles or fat tissues. So basically, if you don't have good insulin production, then your sugars that you eat are just going to stay inside of your body and they don't get broken down to be used. If you have too much insulin, then you become hyperglycemic. So then you break down so much sugar that there's none left to be stored into muscle or stored into the fats, and then you got nothing left to use when you need to use it. So basically you pass out. Glycogen is the lowest, or the smallest form, or the form of sugar that will be used from that will be stored in the muscles and then used when you use the muscle. Okay, so it's good to have glycogen stores before you go for a run, and this is why after a while, when you use up all your glycogen, well, your body's going to start, I'm going to produce insulin here so I can break down more sugars that are floating around in my bloodstream to use it straight away. So this is why eventually, after a long marathon, you got no glycogen left, you got no sugars left or carbohydrates, and then you start to get really dizzy. Okay, there's different types of energy systems. So I'm sure a couple of you probably have heard of how you break down fat for energy, but that's for another topic in another day. Cortisol is the stress hormone, and it can also be thought of as adrenaline as well. So we'll combine these together. Cortisol is a response to too much physical stress or perceived stress, I would say as well, and it can be used to help repair damaged tissue. We can consider too much cortisol will chronically elevate blood pressure and have an issue on many chronic long-term diseases. Epinephrine and norepinephrine is your adrenaline. So adrenaline basically comes out in short bursts and boom, it will really work heavily on your sympathetic nervous system. Okay, sorry, I hope you don't mind me stretching out as I talk. So basically, your epinephrine and norepinephrine will elevate your body's ability to break down sugars, increase your energy production, and increase your nervous system activation of all of the nervous system you need to be on the lookout, because you need to know exactly where that lion or tiger or that armed robber is at every second of every moment as you're trying to escape or fight them. So this is where if you have too many shocks during the day, there's another boost, another lot, and another lot, and another lot, and eventually your body will just produce cortisol, because as we produce a lot of adrenaline, well, that breaks things down, and then the cortisol has to be produced to go in and repair everything, and then all of a sudden you're in a spot of bother because, well, you're constantly producing all these hormones to repair everything, and then nothing can be in homeostasis. Things like testosterone, human growth hormone, insulin-like growth factor, and neurotropic factors, these are all different hormones which do very specific jobs. Testosterone helps build things and makes you feel good. Human growth hormone will basically help everything grow so much better. Okay, this is what a lot of people will inject into them if they need to build bigger muscles. Some people use it correctly, some people don't. Insulin-like growth factor, we will have, well, it's a similar structure to insulin, and will also help the mechanisms of breaking down fats and help support liver processes and so forth with your energy side. Brain-derived neurotropic factors. Now this is a lot for your nervous system, of course, and help improve your cognitive function. Okay, when it comes to sleep, this is a big topic these days. Now, sleep basically allows you to rest and digest, so your parasympathetic nervous system. So, if you don't have a good amount of sleep, you're 8 hours a night, roughly, then you're going to have a poor functioning parasympathetic nervous system. You wake up in the morning, you're really stressed and you can't be bothered, and then you get a little jumpy. Okay, so you can see now my stress hormones, norepinephrine, cortisol increase because, well, I never repaired myself overnight, so now I produce a lot more stress hormones. So automatically, if you're tired or haven't slept enough, therefore, you've increased your stress level because those hormones have to repair you during the day. Have a consideration of little hacks in sleeping: cold rooms, good mattresses, pillows, etc. Waking up and sleeping at similar times. You want to avoid, if you're going to wake up or fall asleep too early or too late. So have it consistent. So the latest data we have on that is roughly waking up at 6 a.m, going to bed at around 9-ish in the morning. So that works on the sun as well, and circadian rhythms are the rhythm of the brain wavelength and frequency of your body, and that has a lot to do with the time of the day. So we've seen that, roughly between 5 and 6 in the morning is the best time to wake up, and between about 9 and 10 o'clock is the best time to fall asleep. Okay, so I would say that's the next section of this online lecture, and we'll get into sports injuries after this. So the sports injuries. So what causes an injury here? An injury is caused by too much of something. So it could be too much weight, could be too much rotation, too much flexion or extension of a joint, or of course you can be hit by something, hit by an opponent on a football pitch, or God forbid hit by a car or something like that, hit your head on a rock. So basically what happens is that all the fibers in the body, whether they're ligaments, tendons or muscles, or bone for that matter, will break open too suddenly and too much. What will happen then, because of that extra force from the landing and twisting of the knee, or the force of a hit of the head and poof, you got to go quickly back, or your head hits here and your body goes forward, you will then tear these fibers, and then you will have to start the repair process. So basically, when you tear a fiber, you're going to be producing a bleed in the broken blood vessel will then have a real problematic situation, because blood will flow out into the body or the extracellular matrix, so outside of where it should be, and then you will have to then the homeostasis process will be compromised. So when we look at injuries, a lot of injuries are in work or sports, and most of them will be to do with muscles and tendons. So when an overload injury occurs, you've overloaded with the bicep curls and you can have a muscle strain. So a muscle strain is just a little rip in the muscle, and it can be graded on 3 levels. A little rip is grade 1, half the muscle off is grade 2, full muscle off is grade 3. So you can imagine any one of those is going to produce pain, but the more it goes up, the more pain it is. So grade 1, painful. Grade 2, very painful. Grade 3, extremely painful. And of course, the time frame of healing and the approach to healing is different. So a small grade 1 strain of a muscle, maybe just a couple of weeks. A grade 2 strain, maybe 4 to 5, 6 weeks, and full muscle tear, well, that's going to probably need surgery and maybe about 12 weeks of full recovery. So, why do we have injuries? Well, too heavy a load, too many repetitions, too rapid of a movement. So this is where people who jump and land on their feet and twist at the same time, they will rupture or tear your ACL or your meniscus or your lateral collateral ligament or your AC ligament. We also have too short of a rest, so you don't recover properly. I do 100 bicep curls one day and I go back and I do 100 more. The chance of the bicep ripping and having a grade 1 or grade 2 strain is significantly increased, because I should wait 2 or 3 days to let the muscle repair. We have imbalanced training programs, so I only ever train one type of training method. So again, this is why we need to do all different types of training: mobility, strength, flexibility, and range training, calisthenic training, swim training, weight training, etc. Running, walking. Irregular sessions, so we don't train for 2 weeks and then we go back thinking, well, I trained a lot last month, I can train again heavy after 3 weeks. No, because your body adapts consistently. If you haven't trained for 3 weeks and you're used to lifting 100 kilos, trust me, you don't want to lift 100 kilos. You're just going to rip the muscles too much. Lack of knowledge. A lot of people, this is the problem. So they don't understand the correct technique. They don't understand that, well, when you're doing a deadlift, you need some activation in your hamstrings before you lift up. So therefore you overload your glutes. They are so powerful that they push you forward. You can easily then, you don't get the synergistic work with the hamstrings and they'll rip. You sprint too quickly too soon, the knee comes right up and out, and then foot lands on the floor. All that landing on the floor, that tension goes through the hamstring. Too cold, you're not prepared. Then basically the hamstring will rip. Do too many sprints, hamstring will rip. Okay, a lot of common factors that have to do with the internal systems is lack of rehabilitation from your previous injury, and anatomical deformities. So you can consider scoliosis, you can consider those unfortunate disabilities where muscles don't grow properly, or the nervous system hasn't grown properly, and so they don't have the coordination. Impaired balance, so they haven't practiced their balance too much, so therefore you give them walking lunges, for example, and they'll be wobbling all over the place. Your lower back, your transverse abdominis isn't strong enough to hold you together, so then you'll end up getting a disc issue. Reduced mobility. I mean, you're never going to ask anyone who's really stiff to do a full back squat because they're too stiff to get all of that flexibility that you need into a back squat. So we can consider overload injuries, the types of damage. So these types of damage are periosteoitis, so that's inflammation of the connective tissue on the bone. Periosteum, itis means inflammation. So the skin of the bone becomes inflamed. We then have tendinitis, so itis, inflammation of the tendon. Bursitis, and this is where we didn't really touch on this, but we have a number of different burses around our joints. These burses are like little cushions and pillows of water, and so they allow for a little spongy something to happen. So if, for example, we have burses on our heel bones underneath our foot, so if we jump too much just on our heels, like toes up in the air, you're eventually going to aggravate that bursa and it'll get inflamed. Or if there's a bursa up in here in the shoulder, so if you do too many bicep curls like this, then the bursa in the shoulder is going to be under so much tension from the tendon that goes around it, it'll become inflamed. Synovitis, so that's inflammation of the synovial fluid. So if you've had a frozen shoulder, it's inflammation of that fluid inside, because that fluid holds very special chemicals, or molecules I should say, and inside the water there's a lot of different cells as well. And then we could have stress fractures or osteoarthritis. So stress fractures is too much, like a lot of runners will get this, stress fractures in their feet, because they've put too much pressure into that bone. Now, why they put too much pressure into that bone is mostly to do with biomechanics. Okay, because certain people can run all day long. We've got people who can run 250 kilometers over a few days. They don't get stress fractures, so their biomechanics of running are perfect. But maybe you and I could go running tomorrow and get a stress fracture in the foot, because our biomechanical movement during the running phase, it's just not up to scratch, and so therefore we overload one bone more than another. Osteoarthritis, we spoke about a little bit before. When we wear away the cartilage in a joint and the bone starts rubbing on bone, then naturally that bone on bone is going to wear away the periosteum. The periosteum then gets inflamed, and then even worse, that wears away, and then you've got osteoarthritis. Traumatic injuries. Have a little consideration now of traumatic injuries. This is what we call the muscle ruptures, tendon ruptures, dislocation, fractures, fissures, and so forth. So basically, any trauma-based. So a lot of this will could come from, firstly, you have an overload injury, and then you keep pushing, and you'll have a traumatic injury. So the muscle will rip off the bone itself. A stress fracture will become so bad, you jump off a big box one day, you already had a stress fracture, boom, fracture will occur, or worse, the idea of a fractured bone can easily come about, of course, if you hit in the leg or you collide with another player playing football or something like that, or you fall with your arm out and you break it. The clinical examination of the injuries. Now, this is pretty important now. So you're going to have to consider how well you can do this and when it's time to hand it over to an expert or call an ambulance, for example. So consider, when you have an injured person in your hands, you need to figure out how much swelling, how much maybe it's an open cut, how much it's bleeding, what the potential dangers are. So if it's an overload injury, well, more rest, and if it doesn't get better, then you would send them to the hospital or send them to a doctor or a physiotherapist. If it's an acute trauma, this is where your brain should automatically go towards considering, ambulance or doctor straight away. So, if a person comes to you and says, yeah, it really hurts when I do this, okay, that's probably an overload injury. Okay, they've overloaded their bicep, they have a little tear in there, they may have inflammation in the bicep tendon, the inflammation of the bursa, osteoarthritis in the AC joint. And so therefore, you have to examine and have to figure out where in the movement it is. Is it more muscular? Is it more tendon? Is it more joint? Because you're doing something like this. Consider the acute care, so you can take a history. How did that happen? When did you first feel the pain? Take a survey, look at the redness, the swelling, the bleeding. Think about the word price, pressure, rest, ice, compress, elevate. If it's nothing serious the person can live with, then try this price effect out first. If everything continues after 48 hours and they still have a lot of pain, well, yeah, it's time to send them on to some other expert. If the pain's decreased after a few days, well, then you can start to think about recovery type exercises and rehabilitation. So with the rehabilitation, again, you should know exactly what you're doing. If you don't, then, well, have a consideration of getting some expert help. Always start on the side of caution. If somebody can easily do on a normal health, when they're healthy, easily do 20 kilo bicep curls, but they've had this injury for a week or so, drop them back down to 5, then 7, then 10, then 12, then 14. Just do maybe reps of 5 or 6 on each weight and see what level you can get up to before pain is initiated. If pain is initiated at a low level, obviously it's pretty serious. If the pain isn't until a high level, okay, well, that's obviously not so serious, but serious enough to try and figure out why. So this is where a bit of research, consultation with a physio or a doctor can really come in handy, because they would probably know a lot more about the nervous system and about joint function than you will straight away. So your experience will also be important into this. I'm sure after 20 years of being a PT, you'll have seen a lot and learned a lot, so you might be able to deal with it more. But in the early stages, I beg you to be careful and always go on the side of caution. Even me, after about 14 years in this game, trust me, I even get things wrong sometimes too. So it says there, full mobility, strength and function is crucial before returning to activities prior to injury. So before you start playing football again, I want you to make sure that your knees can come right up, you can land pretty heavy on the ground, Your legs can go all the way out to the side, and arms, and stretch up, stretch down, full range of motions. Okay. So testing out and understanding the range of motion of joints is an important one. That's for another topic. We can do a little side course about that one. Whoops. Sorry, 1 second. Okay. Then, of course, strength. You know, if you're just playing Sunday football, but this is where a lot of injuries happen. You know, Sunday league football, maybe middle-aged men, middle-aged women, you will have to consider that they sit all week in offices maybe and don't train very much. Then they come to you for some personal training. Maybe it's only 3 or 4 weeks. I'm going to go and play football this weekend. Ooh. Okay. My advice is when you start playing football, play football like we started in the gym. Slowly. Don't sprint. Don't twist too quickly. Let the ball go by you. Don't just twist and jump out and grab it. Okay, because that's only going to, that fast movement is going to then load the leg even more and most likely tear the hamstring, for example. Moving on to different therapies here. We have the therapy of compression, rest and relief, thermal therapy. So compression is when if we have a strain in the bicep or a sprain in the wrist, we can wrap a bandage around it and hold it steady. Now that compression is also going to limit the bleeding of the muscle. It will compress and stabilize the joint. It will also limit the amount of inflammation that happens, so the swelling that comes out of it, like a hand sprain or an ankle sprain, for example. The limiting of the swelling will then you'll be able to start small movements a lot quicker and sooner. Rest and relief, of course, is a very good one. So it's really important. If I was to pull a muscle in my forearm, I would hold my arm up. If I was to rip a muscle in my leg, I would lie on my back and put my leg up, because it's stopping the blood flow rushing in there with gravity, and it'll stop that bleeding inside of the muscle. Of course, if they've got a broken bone, you don't want to walk around with a broken arm with your arm up. It's more to do with bleeding and muscles and ligaments and tendons. Thermal therapy. Now this is hot and cold. So cold will restrict blood flow. Restricted blood flow means less bleeding and less inflammation into the area. So this is where if you feel that you're doing that last bicep curl, it always happens on the last one, and then you can put ice on it. It'll stop the bleeding deep inside the muscle, and hopefully then it won't swell out so much and your recovery time will be a lot quicker. Heat is used after the first 3 days. So ice for 3 days, heat afterwards. Heat will increase blood flow, so therefore increase the ability for the muscle to actually work itself. But if it's still torn, okay, after 3 days, the body should have healed it to the point where you can heat it up a little bit and start moving it. Of course, you have to be very careful. The load of your arm may be enough to start with for the first couple of days, and then maybe a 1 or 2 kilo weight, and eventually over a few weeks you're back up to your 10-12 kilos or whatever you do. Note well, there's a list here of injuries that require hospitals and doctors. So unconsciousness, difficulty breathing, neck pain, abdominal pains, bone fractures, severe ligaments, so dislocations and it's just wobbling around everywhere. Eye injuries, deep lacerations or deep cuts. I've seen biceps ripped off the bone and ends up here. Definitely hospital for that one, because they'll have to go in there and pull the muscle all the way back down and sew it back into the bone. So yeah, use your common sense there, all right? And when in doubt, pass it on to a specialist. Doesn't matter. If you're not sure, I wouldn't be trying to fix it, especially if they're in a lot of pain. Inflammation. So this is where we consider what's happening. So is there redness? Is there swelling? Does it feel hot? Is there pain? Or is there a less ability for that area to function? So if there's one of these things, maybe. 2, a little bit more probable. 3, most likely. 4, pretty much definitely you're inflamed. Okay, so this is where you can consider inflammation. You can consider ice for a few days, and then once, 3 days are gone, I've iced it 3 or 4 times a day for 3 days. Nice. So then we can consider, okay, let's start moving it a bit. Does the pain come back straight away? If it does, maybe it's off to a specialist. If it doesn't, okay, gradual loading starts again. Then we have the type of overload injuries, specific types. So inflammation of the muscle or the tendon attachment to the bone. Your symptoms are going to be pain at the muscle attachment, so near the joint. You're going to be very tender on the touch. When you start poking like this, they're not going to like it. And so then we have a few, you could try some massage, hot cold therapy, or again, if it's really bad, send them on. Myositis or muscle inflammation. So this is DOMS specifically. So this is where you'll need to consider that little rest or active rest. Tendonitis, specific inflammation of the tendon, golfer's elbow, tennis elbow, lateral knee pain or lateral pain here, runner's knee, jumper's knees on the front. Periostitis, that's the skin around the bone, that's going to become inflamed. So you could consider shin splints for that one. Bursitis, I use the one for underneath the heels, but up in the shoulders we have burses. We also have burses around our greater trochanter. So greater trochanter on the side of our leg here. Hit that on the ice. Guarantee you're going to have not only tendonitis, but you'll probably also have bursitis as well. Arthritis, the inflammation inside the joints, bone on bone. Okay, common places there. The hips, back, fingers, knees, thumbs, big ones. So this is where the pain is on every type of movement, whether you're trying to lift the shoulder, pull the shoulder forward, pain's on pretty much every movement there. Skeletal damage, so fractures or fissures. Fissures are a little stress fracture that goes deep inside. And a fracture is a fracture. Broken bone, so we've all been around those. Fingers crossed the bone hasn't stuck out of the skin. Ligament damage, we're looking at, is it a grade 1, 2 or 3? Little bit of a rip in the ligament, grade 1, about halfway through. Grade 2, grade 3 is completely off. So a lot of places that we see this is in our knees, elbows, hands maybe from a fall. So the big one is the ACL or the PCL or the medial or collateral ligaments or lateral ligaments. Footballers have those. So basically you can have a little tweak. Ooh, you can still walk, you can still move, but when you put weight on it, it hurts. A grade 2 would be, oh, I do not want to put weight on this. Grade 3, it's just really wobbly and you just don't know what to do. Ironically, grade 3 tears sometimes don't hurt as much because the ligament has ripped in two. There's no nerve endings. Well, the nerve endings have just been split. So grade 2 can sometimes hurt more than grade 3, sorry. Dislocations, so we can have a partial dislocation, so just a little bit out of the joint and it's easy to push back in. Happens a lot to fingers, they'll pop and oh, what happened? It really stings in my joint of the fingernail. So have that consideration. That can be quick partial and it moves back in, or it can be a full subluxation dislocation and you have to go to hospital for it and they'll put it back in for you. So again, most of these are very visual. You can see a full dislocation very easily. So take that into account. Partial dislocations, yeah, you would follow that Price method of rest, ice, elevate, compress maybe, if you can. Muscle damage, tendon damage, partial ruptures, etc. Now we can have a quick talk about the stretching. The stretching basically is to lengthen your muscle and your tendons. So we have 4 different types of stretches. We have an active static stretch, holding the position. I feel the stretch here. Dynamic, so by bouncing basically. Then passive static stretch, so that would be having somebody do it for me, or if I'm it's a bit hard, but I could say I am passively, if somebody else's hand was here, I'm passively stretching my tricep and shoulder here. And then we have the P&F type stretches, proprioceptive neuromuscular facilitation, P&F. This is where I will bring myself to end range, push back with a little bit of effort, so I'm trying to do this, hold it for about 6 seconds, stretch it even further, push back, hold steady, 1, 2, 3, 5, 6 seconds, stretch even further. So you can see how far I'm getting here now. And this is just very quick and very easy. Look at that. All right, so consider how that works. Is that you're stretching to an end range, trying to contract the muscle isometrically against a fixed point, someone's hand, maybe it's a wall, just for 6, maybe 10 seconds maximum, and then stretch it even further. Go careful, the pressure you push back at is only about 10-15% of your maximum force. Do not fully press. You'll rip something, you'll damage the joint, you'll rip a ligament, damage the tendon, etc. Okay, the advantages of stretching and applying different stretches are to optimize and teach the body the position it can go into. You will then be able to relax a little bit more, because as you're stretching, you're pulling all the fibers apart. Let go, new blood flow will come back in. So this comes back to our hormone system, insulin, testosterone, etc., and cortisol. You'll increase your awareness, how far your body can move, how much you can trust your body there. You can reduce the accidental overstretching of joints or overextending of joints. So if my hand that can now come all the way back, well, if I didn't do those stretches and then I accidentally fell over and pulled it back that far, it would have ripped something in there because my body wasn't used to it. It can help reduce soreness because of the blood, mainly because of the blood flow and working with those micro nerve endings. And in particular, of course, it will reduce the muscle stiffness as well. Consider how the injury, if they've had injuries, consider, well, you don't want to get them to full range straight away. I dislocated my shoulder. Just stretching to here might be enough. And then eventually, you can get them to stretch all the way back. So always consider trying to hold a static stretch for about 30 seconds minimum. You want to be conscious of what you're trying to stretch and how you're doing it. So this is where understanding joint movement is super important, and how one joint will lead into other joints and lead all around the body. So you want to consider where the end range is, or the end feeling. If you're doing it together with somebody, always communicate. Are we sitting, what do you think? 10%, 20%, 30%? Oh, we're getting up to 80, 90. Start that last 10% very carefully. It might just be a millimeter at a time. You're pushing them. Get them to breathe through it, to relax their mind. Because if you breathe and you reduce the cortisol level, well, the better it is there. All right, now it comes down to posture. So considering how we stand, we talked before about kyphosis and lordosis. Okay, so we need a nice little curvature of the neck, lordosis. We need a little bit of a rounded upper back, kyphosis, lower back, lordosis. And naturally, the sacrum will take care of the kyphosis for that one, because it's one fixed bone. So we have posterior type here. So we have, if we're posteriorly leaning, we're going to have short hamstrings. We're going to flex our knees. We're going to drop down a little bit. We're going to have weight on the heels, and your hips will be in a really poor position. And probably you'll overcompensate by having a big lordosis there. Okay, so then we have an anterior type. So I'm falling anteriorly here. So with this, we're going to look at my upper back, my shoulders go round. I want to look straight ahead still. So now my neck has hyperlordosis. Then we can think about the weight. All the weight's all on our front feet. So then I'm always going to contract my calves in order to balance me out. And you can imagine what's going to happen there. Big one is for that is the stomach pressure. So you always got a flexed stomach. And then if you go upright, you can tear your stomach muscles even. Then of course, if we have a normal type, well, hopefully I'm normal. But we're pretty straight up and down. Correct thoracic pressure up here, correct lumbar pressure or abdominal pressure through here. And of course, you're feeling on your feet. You feel evenly between your toes, your forefoot and your heels. So this is where the picture behind me, you can see a straight line going down the side of the skeleton. So this goes through, the straight line goes through an ear, the shoulder or the point of the humerus, your point of the hip or greater trochanter, side of the knee, and the side of the ankle bone here. So what I get you to do at home is draw a straight line on a mirror or hang a string from the roof and line yourself up against it. Try to relax, and then maybe take a picture on your phone or get your friend, do it in pairs, to see where you line up. And then you can put it, if it's on a wall, it's really handy because, or a mirror, because then you can actually, okay, your ear is there, your arm bone is back a little bit or forward, hip there, and then you can actually draw a line and join those dots, and then you can see how out of posture you actually are. All right, and then there's on that last page there, 137, you can see there's a couple of good posture things. We call a kyphosis type of posture. Those usually old men or old ladies will be like this, walking on their Zimmer frames. Or you have a bit of a sway back, you're kind of chilling out like this. Too much. Hips come forward. All right, so there's the different parts of this anatomy physiology lectures. I hope this serves you well. Thank you very much. Take good care.